goal is to complete cancer cell kill within the treated volume. So, anatomic distribution of 1965 tumors that have been treated with stereotactic radiation therapy. So we have lung, mediastinum, liver, pancreas, suprarenal, abdomen, which is pelvic area, obviously, skeleton, and miscellaneous, okay? And there's a number of tumors. So you can see the lung is a lot more than anything else. So we had 1965, almost 1,000 of those were lung. Panel shows a schematic drawing of intracranial stereotactic radius surgery with the gamma knife. Stereotactic frame is fixed in screws in the skull. The right panel shows a schematic drawing of extracranial stereotactic radiation therapy with a linear accelerator. The patient is fixed in a stereotactic body frame. So this is SRS. This is SBRT. So here we're doing probably a rotation or not, individual fields. Illustration of coordinate system in a conventional radiation therapy and stereotactic body radiotherapy. So you have accessory here, conventional. Here you have stereotactic. You have very small area here. Here you're treating a larger area. Okay, so here is something that we can do. You can do it with anybody, with any machine. It's a tool. This is an Electa. This is a Novalis. This is the CyberKnife. This is the Trilogy. And this is actually a Siemens, believe it or not. You can do them with everyone, every type of LINAC.
Is that a CT on rails down there at the bottom, right?
This one?
Yeah.
Could be. It would be nice if we could see the other side. I don't think there's many of them left, to be honest. I haven't seen one for years. So mobilization. So here is a patient that is the stereotactic frame. So what's this doing?
Limiting the movement
Of what?
of expanding the lungs.
Yeah, of the breathing. That's correct. So literally he's in a backlog, but that's all we have. Is that enough for stereotactic? We're doing something like maybe 4,000 centigrade in 5 fractions. Very small area. You think that's enough immobilization?
We don't even have that, we just use a Velcro abdominal belt.
Mm-hmm.
That's it.
Yeah. So this patient is positioned in a stereotactic body frame with abdominal pressure device applied to reduce diaphragmatic motion with respiration. Okay, so total dose, 2 gray per fraction. Recurrence-free survival percentage at 30 months. In addition to the dose, 2 gray per fraction at 5 fractions per week. So that will give us 1,000. Sorry. 10 gray per week. This is the dose here. This is the recurrence-free survival. 84.5 gray. What's that in centigrade?
Gray, centigrade,
Mm-hmm.
400 centigrade.
Actually, 84.50. 84.5.
Oh, great. Oh,
Okay. Yeah. Well, we wouldn't use that much. So here you have, whoops, conventional fractionation, 60 gray in 30 fractions, or 70 gray in 35 fractions. SBRT, 48 gray in 4 fractions, 60 gray in 3 fractions, 48 gray in 3 fractions. 60 gray in 5 fractions, that's probably a bit more normal. Depending on what, of course, you're trying to treat and how small the area is. Reviewability, okay. Clinical rationale for SBRT. So here's the bronchial tree. If you treat, target those homogeneity limits. Spinal cord, heart, esophagus. So if you're treating all of this area inside of these dotted lines, what other areas of the body are you treating? Anybody?
the heart, the lung, spinal wall, inside the lungs.
Spinal cord?
Spine, esophagus. Heart's probably down here somewhere, so you may not be treating. Remember, this is the, what's this called? The carina. So where's the carina? T what? T4. So the carina is at T4. You've got the esophagus running behind here. You've got quote normal lung. And you've got the spinal cord running back and forth. But you would never treat that size of area with an SRS or an SBRT. It's always very small areas. So, CT-SEM, you assess tumor motion, immobilization, minimize motion, breathing effects, small field symmetry calculated considerations, repositioning. So you want high precision setup. Fiducials. IGRT. Relocalization, so again, IGRT, MVKDA rate, implanted marker, motion tracking or gating system, real-time tumor tracking system with implanted markers, and treatment delivery system, specialized SRT, Novalis, CyberKnife, Trilogy. What is gating?
Turning the radiation on and off, movement of,
That's one way of doing
and
it.
it comes up and skin it.
That's one way of doing it, yeah. Gating is basically altering the way people are breathing. The archetypical gating system is what you said, you're actually altering the way the machine works. When the patient breathes in and out over a certain amount of place, or a certain amount of area, the machine switches off until it goes back to where it should be. But that's only if the machine is available to do that. If you don't have that, system, then you have to find another way to do it. So that's where the help in breathing comes in. So, and the abdominal paddle. Techniques are usually in the high technology realm of radiation treatment, that they require more specialized training of physicians and physicists rather than specialized equipment. Physicist has to be responsible for all QA procedures, and believe me, a lot of them to be done before you do an SBRT. Imaging equipment, localization and simulation equipment, whatever you want, whatever you're doing on the treatment machine as far as breathing control has to be done in CT as well. Or cone beam CT. Everything has to be coordinated. So if you're doing a breathing control, whatever, you have to start in CT. Treatment planning and evaluation system, treatment delivery equipment, and treatment verification equipment. Consistent target volumes and organs at risk delineation. Quantitative assessment of target and organ motion during imaging and treatment, just what we were saying. Everything has to start from CT. Set up variation during imaging and treatment, and patient-specific QA. And then we have this down at the bottom here, dose and fractionation strategy. So 1 to 5 fractions. QOD and QD, etc. What are those? QOD and QD. Which one's which? And QD is everything. Yeah. So in some departments, they'll say, okay, we're going to do 3 fractions, but we're going to do it Monday, Wednesday, Friday. Or we're going to do it 5 fractions, but we're going to do it Monday, Wednesday, Friday, Tuesday, Thursday. So that would be QOD, because we don't count weekends. Let's stop here. We can take 10-minute break, guys, if you wish. If you don't wish, we will